So we're going to focus a little bit more on the client as well as the clinician and what their roles and responsibilities are, the relationship between the two, as well as some treatment options and plans for therapy. Our little bubble here on the right, CBT stands for CBT stands for cognitive behavioral therapy. And so that's a very common type of treatment that we have today. So we look at the person's thoughts, right? Their emotions, their thoughts, that's the cognition, how they think and perceive things tied with their behaviors. So we try and reshape their thoughts, then we work on their behaviors, and hopefully give them a different way to view the world, their life, their perspective on things, and then their behavior changes as a result of that. And so, the client obviously is the person that's in treatment, right? They're going to work with the clinician, and hopefully they are an active participant rather than a passive participant in the treatment process. A clinician is the person that provides the treatment. It's just a general term. An important distinction between psychiatrists and psychologists is that psychiatrists are licensed to administer medical treatment and prescribe medication. Psychologists are not. They're clinical psychologists typically do testing. They can do therapy and work one-on-one with, clients in that manner as well. But a lot of them do the assessments. And so if you've ever seen a school psychologist, or if you had an IEP in school growing up, an individualized education plan, you would have seen a school psychologist. They do the battery of tests to help determine what goes into an IEP and what services that child qualifies for. If you go all the way through your highest degree, there's two types of doctorates that you can be awarded. There's a doctor of philosophy and a doctor of psychology. The doctor of philosophy is going to give you a PhD. The doctor of psychology is going to give you a PsyD. So if the philosophy one is still you can get a philosophy in psychology. So my doctorate is a doctorate of philosophy in psychology. If you go the PsyD, it's the clinical route. So I went with the PhD because my master's was a clinical master's, which allows me to sit for licensing to do private practice. So I didn't have to do another clinical degree for my doctorate. I didn't have to go the PsyD route because I didn't need the clinical piece again. So that's why I went with the PhD. So that's the difference is, if your master's, if you're going for your PhD or your PsyD and you don't have a clinical component from a master's and you want to be licensed and be able to practice, you need a PsyD. If you already have a clinical component from a master's and you just want to get that higher level degree, your PhD is what you need. So it just is a matter of, whether or not you're going to do all these clinical internship hours again. But those are the, kind of the differences in the higher level degrees here, the doctorates in psychology that you can get. Just depends on what your overall goal is and what it is that you want to do. But if you get like a master's in social work, or if you get a master's in counseling, a lot of those master programs, or like a school psychologist, a lot of those will offer the licensing that you need to be able to do private practice. Like with my master's program, it was an LCP, and then it's an LCPC, or I'm sorry, an LPC and then an LCPC. Licensed Practitioner Counselor is the first exam that you sit for, and that allows you to be licensed, but you work under somebody else. Once you get so many hours in, then you can sit for your LCPC, which is your Licensed Clinical Practitioner Counselor, and then that allows you to do private practice. So when we go to diagnose, there's a systematic approach to diagnosing. We use that DSM-5 that we talked about in the overview of abnormal psychology presentation to help diagnose, right? That manual gives us a clear set of criteria. The client has to meet X amount of symptoms or criteria in order to have this diagnosis. Without this accurate diagnostic manual, it's impossible for the clinician to decide, what the best route is for treatment, for that individual. The DSM-5, the Diagnostic Statistical Manual, the 5th edition, covers all the current mental disorders for children, adolescents, adults, the age of onset, the prognosis, any research that's looked at optimal treatment approaches. This is what we have right now currently. It's the product of more than 10 years of efforts by hundreds of international experts in all aspects of mental health. It's their dedication, their hard work, which has yielded this volume that defines and classifies mental disorders in order to improve diagnosis, treatment, and research. Who is the World Health Organization? This is, mental health professionals outside the U.S. and Canada as well that aid in this internal classification of diseases. The ICD-10 is the current edition. And so this gives us diagnostic terminology among various countries, not just to diagnose here, but other places as well. If you look up like the DSM-5 diagnosis of the ICD-9, ICD-10 codes, you'll see an alphabetical listing of every disorder that we diagnose that's out there. Or if you just look up I think it's drbob-org or dr-bob.org, I think is what it is. You'll be able to pull it up that way. But it's, so many different ways to categorize major depressive disorder. It's not just one diagnosis, or different types of anxiety or OCD or bipolar or, alcoholism or any disorder you can possibly think of. It feels like the list just goes on and on and on. When I did the crisis work, and we had to, write down the codes and things for insurance purposes, that was the go-to page, to figure out the coding, the numbers that you have to write for insurance purposes. So it's very useful website to keep in mind, when you get to the point where you have to be able to write down codes and things like that. So this is a look at the 5-axis again. This is in the DSM-4, but was removed in the 5th edition of it, but often still used in many agencies and practices today. And so this first axis 1, clinical disorders. These are the major clinical disorders and adjustment disorders that fall on axis 1. Axis 2 is personalities and intellectual disabilities is what we see that fall underneath this category. Axis 3 would be general medical conditions, any kind of health issues that the person has, if they've had a heart attack, if they have kidney problems, if they have diabetes, if they have asthma. Psychosocial and environmental problems fall underneath axis 4. If the person's working or not, if they've recently lost their job, if they're separated from their spouse. And then axis 5 is the global scale of functioning, the GAF score for short. GAF is how we describe that. And that rates their overall level of psychological health. And as well as, the kind of the prognosis, the client's likelihood of recovering from a disorder. And so this is a scale from 0 to 100. The lower the rating, the more likely the person is going to be in need of hospitalization. So this gives you a kind of detailed look as to what you could list underneath each one. We've got depression, schizophrenia, social phobia under axis 1. We've got autism, intellectual disability under axis 2. You could also put borderline personality disorder under there. Something like HIV or AIDS could also go underneath axis 3. Starting a new job, the death of a loved one would be something else that could also go under axis 4. And then the final one would be the rating scale. So, you could say the GAF score is, as we see here, 55. So this is how you break down the GAF scale. So I said on the last slide that the GAF was a 55. That would put our person in moderate symptoms, So, like for example, somebody has occasional panic attacks, they're functioning at a level of 55, occasional panic attacks, okay, not so bad. Let's give them some coping skills. Let's figure out what's causing them, find out what triggers those panic attacks so that we can help them cope and deal so that hopefully those panic attacks start to go away. But you can see the lower the score, the more at risk they are. So if they're having suicidal thoughts, if they're neglecting their responsibilities, they're probably not functioning as well. And so, as we get down into this, 40, under 50 range, let's say, we're more likely to hospitalize for something like that. As we walk through the diagnostic process, we look at the principal diagnosis. This is the disorder that's considered to be the primary reason that the individual seeks help. Are they feeling depressed? Are they feeling anxious? Are they having panic attacks? The comorbid is a situation that occurs when multiple diagnostic conditions occur simultaneously within the individual. So the person might be experiencing both depression and anxiety, which often those two disorders go hand in hand with each other. Differential diagnosis is when we're ruling out alternative diagnoses, so kind of the process of elimination at times. And then case formulation is the clinician's analysis of the factors that might have influenced the client's current psychological status. So that's when you're gathering information and kind of getting a history and a sense of where the person's at and what might have caused these issues that the client is having currently. This is just a chart to give you an example of what some of the categories and descriptions and example of diagnoses may look like. We've got anxiety disorders, but there's several different anxiety disorders. So if somebody, is experiencing intense anxiety, worry, fear, apprehension, it could be panic disorder. It could be agoraphobia or some other specific type of phobia. It could be social anxiety disorder. We also have GAD, G-A-D, which is generalized anxiety disorder. So we lump anxiety disorders underneath the same umbrella, but there's different types of anxiety disorders that one might be experiencing. Same thing with some of these other ones. The feeding and eating disorders. We look at anorexia, bulimia, or binge eating disorder. So there's categories, and then there's different diagnoses that we make under that category or each category. So these are some other categories: elimination disorders, enuresis and encopresis. Enuresis you might be more familiar with. Kids that wet the bed is what we would diagnose them with. Sometimes this is behavioral. Sometimes this happens when kids' bladders just don't develop as fast. Encopresis, I had a client once when I worked as a group home supervisor, and I believe he was 14 at the time, and he had issues with encopresis, bowel movements, and he would have, you'd find little poop balls rolled up around the house. And so you look in like the corner of the living room and there might be a little poop ball that he rolled up. And that was one of the issues that he was dealing with. And he really wanted to go into foster care, but it's going to be, he's a hard placement into foster care when he's dealing with encopresis and playing with his poop. So that was one of his goals, was to, work on that issue so that he could get into foster care. So there's, the sleep-wake disorders like insomnia, narcolepsy, anything related to sleep would be part of that. Obviously the substance-related and addictive disorders, any type of substance use disorder, alcoholism, marijuana, cocaine, heroin, any of that would be under that. Personality disorders, there's just a few of them listed here with borderline, antisocial, narcissistic. There's also histrionic. There's a few other ones too that would fit underneath that, your paraphilic disorders. So again, categories and then different diagnoses or specific disorders we would list under that. When we look at a case study, like with a DCFS worker, we're often looking at the foster care system. Like I mentioned, the kid in the group home. they would all have a case study on them. And so you're gathering a large amount of information on one individual. And so every kid that was in the group home, they would have information from obviously the family. They might have talked to neighbors, extended family, the kid's school, the kid's pediatrician, if the kid had a social worker, other school professionals, anybody that had any kind of relationship with that child that caseworker might want information from those other people about that child. So it's very time consuming to meet and try and contact and find these people to get all that information. And so each child in the foster care system has a case study that's done on them. Obviously, this is a little different than, if we were doing an actual research study on a child, but it's, kind of the same concept as how we would put together a research idea, to go through the steps to gather all the data and all the information. We're just not publishing it in a journal, but we're still going through the steps to gather the information. Something else that we need to consider is the cultural paradigm or formulation. Do you, as the clinician, identify with the culture of your clients? If you go on to get a degree in psychology or counseling or something along those lines, there's a multicultural counseling class that you'll take that kind of walks you through different cultures and working with them and what their beliefs are and how to approach counseling across different cultures and ethnic backgrounds. You want to try and identify as much as you can and offer support, cultural support, but you also need some knowledge. And so if you don't have any background knowledge of that person's culture, it can be difficult and challenging to work with them. But it's also okay to tell them, that you're unfamiliar and ask for more information, or refer. It's never wrong to refer them to somebody that you feel is better suited to help them if you don't feel you're the best person for them, because our first and foremost thought should be in the best interest of our clients. Part of planning the treatment or the treatment plan is talking about how long therapy should take place. And honestly, this should be talked about from day one. When are you going to end therapy? And a lot of times that can seem premature, but what are the immediate, short-term, and long-term goals of the treatment process? And obviously, if they're in crisis, you want to make sure that they're not in danger and that their symptoms are being managed, and whatever the immediate concern is being addressed. And that kind of goes hand in hand with the short-term goals of alleviating as many symptoms as possible, with whatever problematic behavior or thinking or emotions that they're experiencing. And long-term would be to improve their overall life, include more fundamental, deeply rooted alterations in their personality, their relationships, and depending on the situation, the person, what's going on, this might be, a short-term type of therapy where you see them for 8 visits, 12 visits, 16 visits. This might take 6 months or a year or 3 years or more than that. It varies, but you should get a sense of how long this is going to go on for and think about that from day one. Determining the treatment site or what place is appropriate for treatment. We've got psychiatric hospitals, we've got specialized inpatient treatment centers, outpatient treatment, halfway houses, day treatment programs, just regular counseling offices. There's so many options out there for where to get help. We, like the day treatment programs, there are hospitals where you go to the hospital during the day instead of going to like school or work, mostly school because kids do those programs, and then they go home, so they're there from like 8 to 2 or 9 to 3 or something like that, and then they go home and they come back the next day, and usually those programs are 4 to 6 weeks ish is how long you're in there, sometimes less, sometimes more. They don't require inpatient overnight care, but they're, needing help to the degree where they need more intensive therapy on a daily basis to get them in a more stable, situation. Halfway houses we tend to see more often when people are involved with substance abuse, and so they'll go inpatient for like a 30-day program, and they'll be discharged to a halfway house, but they're still involved with mental health therapy and things like that. So the modality or the form in which the clinician offers psychotherapy differs. You might have psychotherapy that, the therapist works one-on-one with the client, just the individualized counseling sessions. Family therapy, where you work with all members of the family, or this could also be all members of the household. You might have other people in your house that aren't necessarily quote unquote family, but you have other people that live in the house. They should be a part of the family therapy sessions as well. Group therapy is where you're talking or participating, working with a variety of people that all have the same issues, same problem. And then the Milieu Therapy, we use this in an inpatient psychiatric facility. So all of the facets of the milieu or environment are components of the treatment process in hospital setting. The clinician's role in the treatment process is about the quality of the relationship between the client and the clinician. This is crucial in determining whether therapy will succeed or not. The client's role in psychotherapy or in treatment is a joint enterprise in which the client plays an active role. Describe and identify the nature of his or her disorder, to describe personal reactions as the treatment progresses, and to initiate and follow through on changes. The outcome of treatment: the client remains in treatment until the treatment runs its course, shows improvement, maintains the improved level of functioning for a period of time. Clinicians can find it frustrating when their clients do not seem willing to follow through on their desire to change. Remission occurs when the individual's symptoms no longer interfere with his or her behavior and are below those required for a DSM diagnosis.